Good afternoon. My name is Julie Servoss. I am the Medical Director for Gastroenterology at Modernizing Medicine, and I'm joined by my colleague, Mantashi, the Senior Product Manager for Compliance. Welcome to our MIPS is Redefining Success for Gastroenterologists webinar. We are very excited to have you join us this afternoon. We will begin the presentation. It will last for approximately 35 to 40 minutes, and we'll have ample time for questions. In addition, I also wanted to let our clients know that we will be distributing the video link as well as the slides for future reference. So here's an outline for our discussion today, the value-based payment outline. First, we're going to ask, how did we get here? Next, what are the new rules for payment? Third, how will we get paid in the future? And then finally, and most importantly, how can GMed and Modernizing Medicine increase the reimbursement pie? So why is value-based healthcare with us to stay? The reason is very simple, and that is that the total Medicare benefit payments are over $580 billion annually. If we look at physician reimbursement, physician payments, they represent approximately 12%, and so this is where we're focusing our attention today. Specifically, specialists like us, like gastroenterologists, cardiologists, we cost more money. And on the left-hand side of that slide, even though we're not listed, I can give you the numbers in terms of how many billions are paid out to gastroenterologists. In 2014, the GI community, we received $1.63 billion, and we represent only 1.5% of physicians, but we represent 2.1% of the spend. So specialists do cost more money, and therefore CMS pays close attention to not only physician reimbursement, but subspecialist reimbursement. So how does CMS plan to rein in costs? Better, smarter, and healthier. This is a CMS announcement in January of 2015. At that point in time, they stated that their goal was to have 85% of all traditional Medicare payments to quality or value by 2016, and 90% of those payments by 2018 should be dedicated or geared towards quality or value. MACRA, or the Medicare Access and CHIP Reauthorization Act of 2015, repealed the sustainable growth rate formula. And it also changed the way that Medicare rewards clinicians for value over volume. So there are two ways that you can participate. There's MIPS, the Merit-Based Incentive Payment System, or the alternative payment model. For these so-called APMs, there aren't any in existence that are GI specific. There are oncology and nephrology-based APMs, and also for primary care, but for the most part, gastroenterologists will be using the MIPS pathway. So what is the Merit-Based Incentive Payment System, or MIPS? It is a modified fee-for-service program, and it really is a rebrand of PQRS, Meaningful Use, and the value-based modifier. In 2017, physicians who achieve a score of 70 or greater will split another $500 million per year. So let's deconstruct MIPS and look at the four components. The first component is quality. This replaces PQRS. The second category is a brand new category, and these are improvement activities. The third is advancing care information, and this replaces the Medicare EHR incentive program, which you know as Meaningful Use. The fourth category is cost, and this replaces the value-based modifier. But please note that in 2017, cost will not be included in any MIPS calculation. It will be implemented as of 2018. So let's focus on 2017. What are your options? Starting on the left-hand slide, if you don't participate, if you're not participating in the MIPS program, you'll receive a negative 4% payment adjustment in 2019. If you submit something, any quality data whatsoever, a minimum amount of data, you can avoid that downward payment adjustment or penalty. If you decide to select a partial year, 90 days worth of 2017 data to Medicare, you may earn a neutral or a small positive adjustment. If you decide to submit a full year of data, you may earn a moderate positive payment adjustment. And we'll see what some potential numbers look like on the upcoming slides. So as I mentioned, the MIPS adjustments will start in 2019, but they are based on 2017 performance. So what you decide to do in 2017 will affect your reimbursement in 2019. If you look at this graphic, in 2019, the sway of adjustments could go from -4%, a penalty, upwards to 4% of a bonus payment. And you can see in 2020, the sway is -5 to 5%, 2021, -7 to 7%. And then impressively in 2022, a -9% downward adjustment or penalty, or you may qualify for a 9% bonus payment. So again, just to reiterate, MIPS measures your 2017 performance will affect and adjust your payments in 2019. Your MIPS score will also be accessible by anyone who has internet access. It'll be posted on this website that you see in front of you. Potential patients can search for you and see what your MIPS score is and can do comparisons between physicians. Now let's look at the MIPS breakdown. On the left, you see 2017, what you'll be required or want to participate in, and then in 2018. For MIPS 2017, note that your PQRS measures represent 60% of your score. The new category of improvement activities represents 15% of your score. And then advancing care, or the old meaningful use, will represent 25%. As I had mentioned, cost will have no bearing in 2017. However, if you shift to the right side of the graphic for MIPS 2018, you'll see that cost will represent 10% of your score, and there are downward adjustments in the improvement activities and quality. Importantly, quality will drop to only 15% of your score. So what do you need to know for 2017? Here are some MIPS projections. If we look at how many providers are required to participate in MIPS, it's somewhere between 592,000 to 642,000. The big assumption for this slide and the next slide is that 90% of all eligible clinicians will participate. This would represent, if 90% participate, we would project $199 million in losses, and this would be the 2019 losses. But there would be a $500 million split for those who receive a score of greater than 70. If we just look at the GI community, we're looking at a little over 12,000 gastroenterologists in the United States. We bill about $1.6 billion in Medicare. Again, assuming that 90% of us participate in MIPS in 2017, about 7.5 of us will get penalized for a total sum of $5 million, but 92.6 would get a positive adjustment of approximately $19 million. And please realize that these are just estimates and based on assumption that 90% of gastroenterologists or overall physicians, DOs, and other practitioners actually participate. So again, these are merely projections. These are not real, true numbers. Okay, so who gets to participate in MIPS in 2017? Physicians, MDs, and DOs are participating in advancing care, quality measures, and the improvement activities. And physician extenders are also included. These are nurse practitioners, physician assistants. Again, note that cost is not calculated in 2017, and when it is introduced in 2018, it's not something that participants like physicians and physicians extenders are reporting. It's really going to be done on the CMS side of the house. So as of the final ruling at the end of October, the exemption category was expanded based upon feedback from our community at CMS. So exemption for MIPS is as follows. Providers who collect less than $30,000 in Medicare will be exempt. For those who see fewer than 100 Medicare Part B patients, they will also be exempt. And if you're in your first year out of residency, you will be exempt from MIPS. Small practices also get an advantage. CMS defines small practices as practices with 15 or fewer providers. There are fewer reporting requirements and improvement activities for small practices. For example, they only have to demonstrate 1 high activity area or 2 medium categories. The concept of a virtual practice in 2018 and beyond will also be an option. In the final ruling, there was also commentary about the elimination of double reporting requirements for CQMs from meaningful use. There's a minimum 90-day reporting period in 2017 and 2018. And finally, large practices will only have to report 2 high-weighted or 4 medium-weighted improvement activities, as opposed to 3 and 6 respectively. And you'll see a couple of slides later on in the discussion where we'll show you examples of high and medium-weighted improvement activities, because again, this is a new category for all of us. And now I'm going to transition to my colleague, Ida Mantashi, who again is Senior Product Manager for Compliance.
Hi, everyone. Julie went through all the description of what is MIPS and definition. I'm going to go through each section of them and show you how you can earn credit using GGAfro. What does MIP mean by quality? So really quality is same as what we had before as PQRS. It changes from 15% of the Medicare patients to 15% plus for all payer patients in 2017 and 16% of payer patients in 2018. That's one difference. The other major difference is that instead of right now you're required to report at least 9 quality measures, you are requiring to report only 6 quality measures for MIPS. You are required to have 1 outcome measure, and if the outcome measure is not available, you can report on a high priority measures. The domain is no longer valid, so you don't have to be worried about that. Cross-cutting measures are no longer requirements, and no special reduction is the scoring to topped-up measure in 2017. So quality deconstructed, no penalty for submitting more than 6 measures, a maximum of 10 points awarded for each measures, and there are bonus points for outcome and high priority measures. Not all quality measures are equal, so the new measures that they do not have any benchmark that can go only to maximum of 3 points. Measure when you have less than 20 eligible patients, get only 3 points. Measures when you report on less than eligible percentage of the patients, maximum of 3 points only. So we CMS just defined them on Class 1 and Class 2 measures. So Class 1 measures are the ones which are scored between 3 to 10 points. For the quality measures, they have at least 20 cases. Measures need to have an established benchmark, need to exceed data completeness of reporting greater than 50%. Now, what are Class 2 measures? They score only up to 3 points. They're less than 20 cases. They're new measures and less than 50% reporting threshold. Can I get more bonus points? Absolutely, yes. You can get bonus points with end-to-end reporting, and you've already, if you're doing ECQM, you're already eligible with it, or if you are going through QC, you are already eligible for that. And there are additional ones for each of the 6 measures required. These are the existing GGAfro measures that you are familiar with it. Again, I wanted to highlight that you do have 1 outcome measures and you have 2 high priority measures. These are the ones it's currently available to you, and you are familiar with all of them. There is no major change to any of those measures. Benchmarking are important, although CMS has not published the benchmarks yet. But we are in contact with CMS almost every day timeline, and then we're trying to ask them to submit that as soon as possible to us so we can actually embed it into the system. It is important because your points get calculated based on the percentage, and you do want to know where the benchmark are standing. Let's move on to advancing care information, which is containing of 25% of your score. Advancing care information is what you used to know as meaningful use. So for in 2017, advancing care has two areas, two basic areas. One of them is basis score, which is 50 points, and the other one is performance score, which is 90 points. There are two areas to gain more bonuses. One of them is clinical data registry or specialized registry. It gives you 5 extra points, and reporting clinical improvement activity gives you additional 10 points, so the total of 15 points. You can score up to 155 points. However, the maximum score that you're reporting to CMS is up to 100. So if you are scoring like 133 and someone else is scoring 100, you both are going to report a maximum of 100. These are the ACI measures. Again, none of them are unfamiliar to you. If you've been doing meaningful use in the past years, this is the sub-selections of those measures. Anything you see yes in front of it, it shows that it's part of the basic. It is required for you to report on those measures. Anything with no is performance. So the more you do, the better off your scores will be. 2017 Modernizing Medicine GI Registry, as we've announced it before, and I'm just going to highlight it here again. We are making 2 registries available to you. For specialized registry, you can register to that as long as you have a minimum of 1 disease. For this registry, you'll be qualified for them. Now, I got a lot of questions that you're asking me if you are required to register on both of them. The answer is no. Just registering to one of them will give you the extra 5% bonus. But we do require, if you have eligible patient for both areas, please go ahead and register. It doesn't cost anything, and it's very good to have. Improvement activity category is the area you've never been familiar with it before. It's brand new to MIPS, and it's something that it's 15% of your scores, and I believe it's something that you can easily score on it. Let's dig into it to see how can you score with what you currently have. Now, again, there are 93 measures or activities available to you that you can select any of them. All 93 of them are available to you through the GGAfro. You can select any of them. However, we highlighted here a few of them which it's available through GGAfro, but just using GGAfro, you can get credit with it. First one is the use of direct mail when you are using this after hours or during the weekend. That one is a high weighting measures, and it's eligible for ACI. The other activity you can use to gain credit for improvement activity is patient portal. Implementation of the regular reviews. You can use advanced patient search or GInsight. If you're part of the GInsight already, you can automatically, select yes for this for the GGAfro. Or if you're not and you're using the advanced patient search, you can also be eligible for this activity. Medication reconciliation. You are familiar with that. It used to be one of the measures. If you still continue using that, you can select this activity. It's also eligible for ACI bonuses. Timely communication of test results. You can use it through the portal. You can use it by letter or a phone call. Referral letters. Referral letters, again, is something you've been using it in the past. It is eligible for the ACI bonus and a weight medium. Another direct mail activities. So as you can see, just using a direct mail gives you two activities, one high and the other one medium. The other one is participating in QCDR. If you are part of GI Quick or you're part of our registry, you can actually check this one as well. Cost category, again, has no weight in 2017. It will have weight in 2018. MIPS reporting option for 2017. Okay, so you do have options. I'm going to go through all the options that is available to you. Been doing some of you have been doing qualified registry by, for example, doing measure groups. Qualified registry will be available to you in 2018 to go through MMI registry. QCDR is currently available through if you are participating in GI Quick. If you are doing ECQM, you're reporting as EHR. Some of you have been using claims. Claims is still a valid submission form. However, we do not recommend you to use claims because it gets no extra bonuses. Web interfaces is still available. It's for the larger practices and for the ACO practices. Now, what is really important for you to know, and it's very different than what you used to have, is that if you are reporting as GPRO, you have to report in all three other areas as GPRO. You cannot have a mix and match. And if you are reporting as individual, you are going to report individually all three sections. Now, how do we navigate this water? Maximum your chances. So here's our recommendation: report at least 90 days to a full calendar year. Report at 6 quality measures and give your benchmark in real time. Highlight your awesome or high priority measures. Focus on those measures. Report your advancing care or MU bonus measures. Your certified EHR allow you to participate in improvement activities. So make sure you're familiar with those activities and select them. Get a score of greater than 70 for the extra dollars. How can GGAfro help me? Okay, so we're so excited about our new benchmark. This is what you see in GGAfro. It will come in 4.62 release. You will see all the areas that you need to get good score. With clicking inside each one of those cards, you'll be able to dig into more information and see how you're doing. This is what your quality dashboard looks like. It's very similar to what you currently have with your PQRS measures. You can select whatever you wanted to report and ask for your report data. This is your advancing care dashboard. Again, there is a basis score and performance score, and there's a selection of yes and no questions and the measures you require to report, and the measures that your performance will be calculated based on that. This is your improvement activity dashboard. As I said, it contains all 93 selections. You can select any one of those you want. We are having a little abstract to tell you which one has give you extra ACI credit. It has 2 sections of small practices and large practices. So if you are less than 15 individual provider in your practice, you consider small practices, and you are 15 or more, 16 or more, you consider large practice. And so the number of the measures you select and the points are different based on the size of your practice. So if you are practice, you're a small practice, you need to report up to 20 points, and if you're a large practice, you need to report up to 40 points. I just want you to highlight one more thing, that whatever improvement activity you're reporting in 2017, you cannot report the same measures in 2018. So you need to select a different one. And that's what we are trying to give you, as many options as we can. So excited to show you this few improvements that we are introducing with this load. One of them is configuring your HDI report to run at night and be sent to you via messaging as often as you want. I know many of you have been asking for this feature, so it is coming very soon. The other option that we got a lot of questions from you, especially last webinar that Julie and I did. You'll have an option now to drill down on the CQM report. You will be able to see which patients is included in your report. Coming in 2018, integrated qualified registry quality reporting. We're very excited to introduce a subset of the measures that are very much focused on your practice, and you'll be able to report that through MMI registry. So it is coming in 2018, and we're defining the measures as we speak, and we're working on it. Additional information that you probably are interested to know is 2015 edition certification. For the 2017, we're not required to be in 2015 edition certification, so the 2014 edition certification that we currently have will cover the MIPS first year or 2017 submission, although we are required to go to 2018 certification. We currently are reading the requirements and working on it, so we will have that. We are scheduling to be certified by Q3 of 2017, so at the beginning of the 2018, you will have everything in place. It's a lot of information. I know the very first time you read the rules, you probably panic. We are there to help you, so do not get panicked. Everything is in the system, and we're very excited to show you the new rules are actually easier for you to report. All right, so I'm going to start a quick poll before we start answering the questions.
All right, so the first poll question is, what was your knowledge of MIPS prior to this webinar? You should see a prompt on your screen. If you can participate, that would be great. Wonderful. So 55% of you with a basic knowledge, 13% with advanced knowledge, and 2% experts. That's fantastic. I will say that Ida Mantashi is an expert at MIPS, so again, we are here to serve all of you. And any questions, you'll receive the video link and the slides. Any questions that are generated will be very easy to follow up with any of us for questions. Next polling question, was this webinar helpful? Here we go. After these polls, we'll move on to some questions. Wonderful. Over almost 98% thought that this was somewhat or extremely helpful, so thank you very much for that feedback. We're happy to serve. That's exactly what we wanted to achieve. And the final poll, would you like to learn more about GMED's products and services? Great, so the majority would like to learn more about GMED products and services like GAdvisor. Fantastic. Okay, I'm going to switch over to some questions. I'm going to close my poll. Great. Okay, so the first question, are there slides we can print out? As I mentioned at the beginning, the video link and the slides will be sent out to everyone registered as well as all GMED clients. So we will go ahead and send those out. You will be able to print the PDF version of the slides. Next question.
Will GGAfro be ready if we want to try for a full year in 2017? Yes, absolutely. All the MIPS requirements are going to be available to you in Q1 2017. Okay, so that's a long question. Let's read it. The advisory board and MGMI does not agree with your slides that a full year submission can earn more than 90 days of submission. This will, yes. Okay, so that's actually a great question. I just asked a consultant at CMS that if there is any difference between 90 days or a full calendar year. The answer was yes. However, they can't give us the exact amount that how much is the difference because you know, they need to know how many people submitting versus how many people are not submitting, and then based on that, they would know exactly what's the difference between 90 days if you're reporting only 90 days or if you're reporting a full calendar year. But yeah, we don't have the exact data, and CMS promised us that if they have more information, they will share that with us. Okay, the 15 provider, that is by teen, correct. Yes, the 15 providers are by teen. So that would be based on the teen identification number. You went over the benchmarking very quickly. Can you go over that again and a bit slower as to how and what we are benchmarking? Sure. I went through it very quickly because the data is not available to us yet, but I can speak into it a little bit further. So each measure has a certain benchmark. So if, for example, if you are scoring 51, and one example would be like measure 130, for example, right? And the benchmark or the average is 150, you doing fantastic. You're going to get incentive, you're doing pretty good, you are above the benchmark. If you are scoring 150, exactly like the what the benchmark says, you would get nothing. You are just breaking equal. And if you are scoring like 149, you are below the benchmark. And chances in 2017, you'll be okay, but starting 2018, you're going to have to be careful with that. You don't want your number to go below the benchmark. Now, benchmarks are based on the last 2 years of the scoring, which is available. And again, we're trying to get that last 2 years of the score from CMS, but it has not been published yet. So they're running like about 2 years behind. So some people lost sounds for some reason. We will make the video available. We only utilize GGAfro. Will we be able to support through GMED?
Report.
I do not through the GMED. Okay. Will we be able to report through GMED if you are part of the GGAfro? I do not know the answer to that question, so I have to get back to you. The webinar will be recorded and will be emailed to everybody. Well, will for the 62 be released? It is scheduled for the end of February. However, we would like to highlight that we're planning for the Q1 of 2017. So soon. Can you send a list of PIA available in GGAfro and send all the slides? Yes. Will this slide be made available? Yes. So we're getting a lot of questions about the slide. Can you verify about not reporting same measure in the 2 separate years? Yes, I can actually review it again, and then we had a bunch of questions submitted to CMS to see how it's really working. But improvement is really to CMS to know that you're doing some steps, you're taking some steps to make improvement to your practice. And therefore, they want you to change the improvement. If you've already recording something this year, the assumption is that you continue to improve, and then so you're going to have another improvement for next year. Again, we have plenty of improvement for you to select within our system or using something external. So nothing to be worried about. So I think we answered the 4.62 release already. One of the first slides shows the difference for 2017. Will we report on all patients in 2016 as opposed to Medicare patients in the past? Yes. The answer is yes. It's going to be based on all your patients and not just the Medicare. Is the MIPS dashboard available? Or can we show how to access the reporting? Yes, the dashboard is available to everybody. The MIPS dashboard is going to be available to every single person. However, the quality section of that, it depends on which system you are using. If you are using ECQM or a PQRS within GGAfro, you will see your number. Although if you're using another system, another registry or something, you will not be able to see your score in GGAfro, but you will see the rest of your data. When is 4.62 going to be available? I think I answered this question a few times already. I have a physician who will join our group in September 1st, 2017. Out of the residency, although she will have only worked 3 months with us in 2017, she will be able to opt out for full year in 2017 or September 16, August 18. Yes, so it depends on how you're reporting. If you're reporting as GPRO and you would like to include this physician to your reporting, and it depends on if you wanted to report on a full calendar year or just a section of the calendar year, you can actually send me more information. I'll be happy to look into it and help you out with that question. When will we answer this question? If only 80% of the quality, does the bonus get higher if their penalty gets bigger? If only 80% qualify, does the bonus get higher if their penalty gets bigger? So yes, CMS, the way that CMS is, I think it's associating the bonuses versus incentive is that, the 50% who are below the benchmark are going to pay penalty, and that money goes to the other percentage who are doing better. So that's how the money gets associated. So the better you do, the more money you get. Some of the questions, I can't answer if there are more details. So I will send you the email after this call. Please, send us a reminder. If you did not get the answer to your question, I need to explain it a little bit longer. So if you would please just send Julie and I an email and I respond. We use GI Quick for PQRS for our physician, but what can we do for the PAs? So yeah, you can actually use, just like you did ECQM with us, and do specialized registry for extra bonuses. There are, again, for 2017, hopefully we give you the MMI registry options as well that you can use for both physicians and PAs. Does the large or small practice criteria apply to providers reporting individually? Yes, it doesn't matter. The large and the small practice criteria applies to everybody, even though if you're doing individually. How do we sign up for the IDS registry, for the Riskless Registry? So yeah, that's a great question. We are going to make a form site available to you. The announcement, I'm working with legal to make that available as soon as possible. I know we are at the end of the year and you wanted to have that as soon as possible. So we are going to send all of you an announcement. And if there's going to be a form site, you register with us. We automatically check to see if you have a patient eligible for that. And it's very simple. And you'll be just sign in. Again, there's no cost to it. Please, stay tuned. We're working as high priority on that. You will see it very soon. What version of GGAfro has the MIPS enhancement included? It's for the 62. Will GI Quick be considered for quality reporting in 2017? Yes, absolutely. They will be considered just like what you did before. They would be part of the MIPS. As far as we know, and I think we have several meetings with them. They're going to be ready. Are we going to add more CQM measures? The ones in GGAfro are not very applicable for GI. What about the GI reporting set? So it's excellent question. We don't see a lot of CQM measures that are applicable to GI, and that's the reason we are trying to, set up a registry, a quality registry for you guys to go through MMI registry. So yes, we are selecting about 10 to 12 GI-specific measures. These are PQRS measures, not ECQM. And once they're available to you, you'll be reporting it through MMI registry. So, but those are going to be super easy for you because they're very GI-specific.
And examples of those PQRS measures would include the hepatitis C measures as well as inflammatory bowel disease. So we're really targeting as GI-specific PQRS measures as possible.
When is for the 62 release for class clients? Again, I don't have the exact date, but we are going to make that available to all of you, including our cloud users, Q1 of 2017. Oh, would it be available for the cloud users? Absolutely, yes. It would be better to have your power for the slide available ahead of the time. Next time, that's a good comment. Thank you. Will you be adding more GI-specific measures? Again, we are planning to add that. I don't have the exact timeline for that one, but it's definitely going to come on time for you to be able to report 2017 calendar year. And it goes back. So once you see the measures, we give you the ability to go back from the beginning of the year. Yes, for claim-based, I heard you don't get bonuses. That is correct. So CMS really wants to give advantage for people who are not doing claim-based. So the claims-based do not get bonuses. What is the best contact info for MACRA questions? So if you do have advisory services, please contact them directly. If not, I'll be happy to answer any question. Again, it's Ida Mantashi, I'm product manager of the compliance. Do you have documentation on how to meet ECQM in GGAfro? I will search into that. I think there are documentation. So again, after this meeting, please reach out to see. I'll find out how we can help you with that. What was the CMS reasoning behind not allowing to use the same measure in 2017 and 2018? Again, No, this is only for advanced. It's the same measures for quality. It's the same measures for ACI, all of them. This is only for improvement. It's only for improvement, and as it says that they want the practice to be improved. So that's the whole reason they want you to improve your system year after year. Again, if I'm not clear, it's the same measure. You can absolutely use the same measure for quality. You can absolutely use it is the same measure for ACI. This is only for improvement. I would like to know how we are doing compared to other GI practices for 2016. Are there benchmark for existing CTMs for 2016 submission? I don't think for 2016 we don't have a way to do this comparison and this benchmark. And again, you will get compared not to other GI practices, but to everybody. Right? So the measures you select has to be very selective because it's for everyone. 2016 benchmark is not available. Do we have to report the ECQM in GGAfro if you are reporting via GI Quick? No. If you are reporting from GI Quick, you already covered. You do not need to do ECQM. However, again, your calculation obviously we don't show in GI Quick in GGAfro, but you probably have a dashboard and you know how you're doing with GI Quick. But the answer is no. If you are part of the GI Quick, that's enough. If you are registering with our registry, what type of training is available for you? So it's very simple. You're just registering with us, and you're just going to give us permission to use the data. It's going to be quarterly reporting to you. So if you are part of our registry, you will receive the email coming from us saying that you have how many patients and what are the population that you are using, what medication you use, the basic stuff. There's nothing required from your side, so it's pretty simple. Can we submit a blend of GI Quick and GGAfro for MIPS measures? Yeah, so the answer is yes. So the submission is actually a great question. The submission is different in each area. You can submit through, you can submit like quality through GI Quick and ACI through our system. You can do mix and match for submission. So the answer is yes. Can I publish my contact information so that we may address future questions to the I don't know. Yes, we can publish the information. If you are using a different system in our lab and utilize GI Quick, how easy it is to use GGAfro dashboard or registry, I would like to know more about that. So if you would please contact me with more information so I can evaluate how easy it is to switch. Are the exemptions based on the provider's patient count or revenue dollars during the 2016 and 2017? Based on the provider's patient count or revenue dollars during okay, so the revenue dollars, the cost doesn't come in until 2018. Again, cost is it's not coming into the picture until 2018. So providers who collect less than 30,000 in Medicare for 2017. So I hope I answered the question. I don't know if I answered that exactly. Julie, you want to highlight that?
I think the question is in terms of the exemption for MIPS. We had made the comment that providers who collect less than $30,000 in Medicare would be exempt. I believe the question is that in the 2016 fiscal year or 2017?
Oh, that's 2017.
Okay.
So these informations are for 2017.
So if a provider collects less than $30,000 in Medicare dollars in 2017, they will be exempt from MIPS.
Correct.
Okay.
Correct. Correct. These are MIPS requirements. The question is, are we going to give presentation on how to meet PQRS measures within GGAfro once available? Absolutely, yes. We are going to have webinars. We are going to have training materials on how to report and how to score well. So yes, it's definitely going to help you out a lot with those measures. Okay, when will you send out the information on how to configure GGAfro and capture the new PQRS GI measures? If we want to report for the whole year, we will need to have this in place by January 1st. By January 1st, we are not going to have all the PQRS measures in place. It is coming later. We're thinking of either Q2 or Q3, but it does go back to the beginning of the year. So it's based on your practice and calculate the data. So on the January 1st, you will have all the options you currently have, all the CQM options and GI quick measures. No, you said that I heard that you mentioned that reporting through the major groups. Will it still be an option in reporting in year 20? Is that true? No. No, I have to be clear, the difference between GPRO and major groups, they're different. So major groups are no longer available in 2017. That's where you were having a selection of certain measures and you were reporting as individual on that certain measure. That option is no longer available in 2017. GPRO, however, is available in 2017. Please send your CQM info to all. Yes, absolutely. Will the meaningful use attestation site be available, or are we submitting our measures value through MACRA data submission process? That's excellent question. So what you used to do as a submission for meaningful use will continue to be available to you for reporting ACI section. So ACI and improvements. For ACI public health reporting, if we are registered for GI Quick, will we meet the measure? If we cannot do syndromic surveillance in our state, and we do not do immunization. So yes, that's the optional measures. And if you're using GI Quick, you're going to get the bonus points. So it is not a must, it's not required measure. Please, yes, I will be sending my email to everybody again. So what outcome measures are available provided GGAfro? We need to have at least one. That's a great question. I do not have that information with me right now, but I'm sure they have outcome measure. I will reach out to them to verify that and follow up with this question. It's a good question. I currently use meaningful use through GGAfro. Will this bill be same or in addition? If you're currently using meaningful use, it's going to be exactly this. It's very similar to ACI. Actually, it's a subset. So your meaningful use, modify meaningful use 10 measures right now. It's going to go through 6, I believe. It's less. It's a subset. It's less than what you have. Since MIPS will include the physician's assistant, then how will reporting be written GI Quick since they only capture provider procedures data? So we're going to have to be looking into it right now. It is for everybody to be calculated. So yes, it's a good question. I will answer that specific question later. would be helpful to read the question that are asked because, all right, sorry about that. I'm trying, it's a lot of questions. So yeah, I understand I'm not reading the whole question all the way to the end. I'm trying to answer as many as I can so we can catch up. If you have MIPS questions, you're welcome to send an email to me directly, or if you have advisory, actually should go to the advisory first. If you do not have advisory and it's a MIPS general question, please open a ticket and we will be happy to answer it and get into it. So I'm almost out of time.
Wonderful. Thank you, everyone, for all of the questions. We've received some great feedback on how to improve this in future webinars. Just a couple final comments. As we stated at the beginning, the video link and the slides for this presentation, as well as the email contact information for Ida Mantashi, again, Senior Product Manager for Compliance, and my email will also be included in this communication. Please expect that within the next 24 hours. And also I wanted to comment for those of you who were able to attend our GMED Summit, we did get a lot of feedback about the timing of our webinars, that people would prefer the evening. So we're going to try to move our upcoming webinars, again, on the PQRS specific measures and future upcoming hot topics to the evening. But please rest assured that we will continue this new trend of sending the video links and the PowerPoint slides to all GMED clients so everyone has availability. So again, thank you very much for joining us for this webinar, and we look forward to hearing from all of you.